The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with the Genuine Article, and I'm talking to Benjamin Chow. And Dr. Chow is Associate Professor of Medicine and Co-Director of Cardiac Radiology at the Ottawa Heart Institute. And he's the first author of a very interesting paper about to be published in JACC that deals with the question of how best to use computed tomography angiography. This is a very powerful technique, potentially can yield a great deal of information, but we're feeling our way along as to exactly how to use it. And Dr. Chow and his colleagues are publishing a paper that shows the prognostic application that can be derived from these studies. Ben, why don't you summarize quickly the study and the results?
Oh, thanks very much. We prospectively enrolled over 2,000 patients who underwent a cardiac CT at the University of Ottawa Heart Institute. We followed these individuals prospectively for approximately 1.5 years and followed them for hard outcomes such as cardiac death and non-fatal MI. And we examined CT variables such as CAD severity, LV ejection fraction, and something we call total plaque score, which is an indirect measure of plaque burden, as predictors of cardiac events.
And what did you find?
We found that all three were actually independent predictors of future events. Looking at CAD severity, as patients had more and more disease and higher risk coronary artery disease, the more likely they were to have a cardiac event. Similarly, LV ejection fraction, with worsening LVEF, patients did worse. And with total plaque score, as the plaque burden increased, there was incremental value in its assessment and its predictive value.
And all of these findings were incremental over a standard clinical evaluation, including conventional coronary risk factors.
Correct. At the time of CT coronary angiography, we took a medical history, and there was an opportunity for individuals without previous blood work to have blood work done and have risks assessed. But incremental to that, we found that the CT variables were predictive of future events and were incremental to those clinical variables that we did take at the entry points.
Well, what your study really is adding to some previous studies showing the prognostic value of CTA is that you can garner some additional information. The ejection fraction is clearly variable. A plaque score can be derived, and this is additional information that should be taken into account. But could you get that same information, say, from a history of myocardial infarction or congestive heart failure?
That's an excellent question. We were able to obtain that information. Interestingly, we've found that many individuals who've had a myocardial infarction, or at least give a history of a myocardial infarction, indeed have not. Similarly, we did obtain a history of whether or not patients have had heart failure, but only a small proportion of individuals enrolled into our study had a history of heart failure, and as well, a proportion of those would have had diastolic dysfunction and heart failure from diastolic dysfunction.
So your data clearly have some limitations in the sense that we don't know how this would work out in a really low-risk population. And, of course, the issue always comes up, do we have a therapy that should be applied, especially to a low-risk population? But nevertheless, a very important study showing that CT angiography can yield some very significant prognostic information. Thanks very much for being with us.
The Genuine Article. Discussion and commentary based on articles from JACC.